Today we're going to be talking about the preventative maintenance with orthotics if someone were to come in the office with chronic back pain, hip pain, knee pain, or ankle pain. And this is your typical orthotic, and we're going to have Dr. George Corey, who's been a practicing chiropractor for 30 years now, explain to us the mechanisms of this.
We will do a very basic, very quick overview. If a patient were to come in with a chronic low back, hip pain after you're taking your history and there is no trauma induced, you may want to look at some of the internal structures and how the gait cycle is related to knee tracking mechanisms and how that interrelates with chronic low back pain. Also in terms of leg cramps, chronic foot pain, plantar fasciitis, Achilles tendonitis, and some other things. The first step to do is to look at the basic weight-bearing mechanism. As you're all aware, I'm sure, this would be your sacrum. Hips are here. Femur heads. And ideally, if a patient were to weigh 100 pounds and we center lined, ideally our weight-bearing mechanism is 50-50. Also in this configuration, keeping in mind that the spine is here, our muscle attachments would also be 50-50, therefore the workload would be the same. If we took this same basic structure and we deviate it from the norm, and we now take a sacral base angle as such, and we have a differential in the femur head height, we have a differential in the sacral base, we have a difference in the height of the ilia. Consequently, this could potentially end up with a compensatory deviation here. And now if we looked at the muscle attachments, we take point A, we take point B at a resting state is going to have a greater workload. Also, our weight-bearing line is now coming off at 90 degrees to our base angle. The sacroiliac joints are contingent on the tracking of the ilia. If we took this down one joint further and we added the knee joint, this will also affect the tracking of the knee joint. Some of you may be aware, looking at this internally, the iliopsoas muscle, which is attaching to the vertebra, is coming down through the pelvic wall, bypasses the inguinal ligament, attaches to the lesser trochanter of the femur. With the greater workload, if we take a level line here and a level line here, our differential in the muscle pull is at a resting state. The same thing is true with the iliopsoas muscle. If this is pulled tight, we have a rotational stress on the head of the femur, which is going to rotate the femur internally and therefore affect the knee tracking mechanism. What would be done on this is you would take a standing weight-bearing x-ray, measure this differential here, observe the patient's gait cycle, take a full case history, and in terms of a long-term remedy for this, as the knee deviates, so would the foot in either pronation or supination. As the gait cycle is observed, you would take a negative weight-bearing cast on the patient's feet. The x-ray would have to be taken standing and measurements taken off of a weight-bearing film, not a supine film. Once the casts are made, Measurements are then taken from the iliac crest, from the sacral base, and the femur head, and the proper corrections will be built into the orthotic in terms of either a heel ramp, pronation wedges, supination wedges, or a metatarsal bar, or a combination of all three, to return this to the correct weight-bearing stance, therefore giving the patient something long-term to use both their body weight to their mechanical advantage and use their gait cycle to their mechanical advantage to reduce the stress not only on the vertebral column, the discs, the iliotibial bands, and reduce the pressure on the knees by centering the tracking mechanism. It will therefore also reduce plantar fasciitis and lessen the stress on the Achilles tendon. So in a long-term situation, along probably with the proper NSAIDs or whatever else is required, this is a good adjunct for any patient, long-term, no side effects, custom made.
Okay, and this is the standard orthotic, and if you go down here, it's right into the foot and will prevent my arch from falling, and traction of the foot would be perfect. Guess that